Good morning, everyone, and welcome from Toronto, Canada. My name is Anna Sangster from the International Federation on Aging, and it is my pleasure to be moderating the Strengthening Multi-Stakeholder Country-Level Engagement to Advocate for Adult Pertussis Vaccination webinar, which aims to consolidate the views of experts, patients, and aging organizations representing millions of people to respond to a significant gap in information on pertussis, help influence change in adult pertussis vaccination policy, and increase the uptake rates of adult pertussis vaccination more broadly. It is a privilege this morning to be joined by three speakers who will be sharing their expertise and experience with us. Before I hand things over to our first speaker, however, I wanted to briefly review some general housekeeping. First, the webinar recording and slides will be made available to all registrants post-webinar. Second, please ensure that your camera and microphone are turned off at all times throughout today's presentation. Lastly, you are encouraged to use the chat function to submit any questions you may have regarding today's presentations. Questions are welcome throughout the session. However, all questions will be addressed during the dedicated Q&A period after all presentations have been completed. With that said, it is now my pleasure to introduce our first speaker of the day, Dr. Javier Garau, who is an associate professor of medicine at the University of Barcelona, and who will be sharing some of his invaluable knowledge on the epidemiology of pertussis and consequences on older adults and those with chronic comorbid conditions. Dr. Garau, thank you so much for joining us today. The floor is yours.
Okay. Thank you very much, Anna, for your presentation. Good morning and good afternoon to everyone. I like to speak about a disease, a contagious disease, that it's been with us for many centuries, probably is one of the oldest infectious diseases. And I'd like to participate in this webinar that will highlight the importance of adult vaccination, specifically today in this particular disease. As I was saying, this is an old disease. In fact, there is a Chinese description in the 4th century and calls this disease the 100-day cough, indicating a very important feature of the disease, which is the long course of the clinical respiratory tract infection that at least lasts or can last for more than 3 months. The second very important characteristic of the disease is this classical inspiratory sound that is made at the end of an episode of paroxysmal coughing. And this is named and is well known by the name of whooping cough. As you know, it's a vaccine preventable bacterial disease. Specifically, it's caused by Bordetella pertussis, a gram-negative bacillus, as I will show you some details in a minute. That was first reported by Bordet and Genju in 1906. Interestingly enough, vaccines were produced over the following 2 decades, quite early, in fact. As I said, is a gram-negative pleomorphic aerobic bacillus that, in fact, encompasses 10 different species. Bordetella pertussis is the most important one, certainly for humans, followed by Bordetella parapertussis that produces milder disease, but is quite similar to, in fact, to the classical Bordetella pertussis. There are other species of importance in humans, like Holmesi and Bronchoseptica, that produce pictures that are not typical of whooping cough, but can be certainly severe enough as to bring the patient to the hospital and cause death. It's interesting to know that this gram-negative bacillus is very active from the biological point of view, in the sense that it's able to make many different proteins that act as toxins and that explain its pathogenesis and, in fact, its immunity as well. Most of these virulence factors are under the control of a single genetic locus that regulates their production, resulting in an antigenic modulation and phase variation. It's a very, very communicable disease. In fact, it's much more contagious than smallpox, rubella, polio, diphtheria, mumps, and many others. In fact, it's 3 to 4 times more contagious than most of these already mentioned infectious diseases. We call that the rho zero factor is around 15, as compared to, for instance, diphtheria, which is much lower. It's around 4 to 5. The attack rates, when this occurs in a household of non-immunized people, is close to 100%. Interestingly now, and this is a good example of the impact of vaccine, this goes down to 20% within households in well-immunized populations. The infection indeed is worldwide, with classically cyclical outbreaks every 3 to 5 years. And it's a pattern that in fact has persisted despite widespread immunization. Now it occurs in all months. However, at least in the Northern Hemisphere, particularly in North America, its activity clearly peaks in autumn and in winter, as happens in fact in Northern Europe. Now, the vaccine coverage rates are still low in many countries. This is one of the main reasons to justify this webinar today. The non-immunized populations, the incidence peaks during the preschool years, and well over half of the children will have the disease before reaching adulthood. So although the classical idea remains true, is a childhood disease, it is obviously important to know that young adults and certainly older people, as I will show you in a minute, are also able to get infected and reinfected by Bordetella pertussis. In a highly immunized population, the peak incidence is among infants up until 10 years of age. And this again is understandable because with acquired immunity and with age, there is an increasing resistance to the clinical infection by Bordetella pertussis. Although adults appear to contribute to a smaller proportion of reported cases of pertussis than certainly children and adolescents, this difference, in fact, may be related to a greater degree of under-recognition and certainly under-reporting. Probably this is changing today because we start to have access to very accurate and sensitive diagnostic methods. Molecular biology in this sense has helped a lot. And today a PCR very confidentially can make the diagnosis of Bordetella pertussis in a respiratory sample. It is thought that maybe up to 20% of adults with cough that do not improve within 2 weeks are probably in an area that is suffering an epidemic of pertussis can be due to this organism. It is also important to remark the asymptomatic infection is quite common and appears to contribute to disease transmission. And this explains some of the small outbreaks that are present in countries with a high immunization level. Now, according to the World Health Organization in 2019, you have here the global figures. The number of cases on the left side of the slide, and the incidence rates on the incidence of the immunization coverage on the right side. And as you can see, in the last 30 years, there has been a constant increase in the immunization coverage, globally speaking. And this is also proved by official coverage. And as you can see, both lines are pretty similar. Now, in absolute numbers, this is a global picture of all cases of pertussis, regardless the age. You can see that there has been a constant and remarkable degree reduction in cases from 1980 to 1990. Then has gone down much more slowly, with some peaks indicating epidemics in different countries. I like to show you this particular study because addresses precisely the point of infection in older adults. This is a study recently published in older adults from the 6 European countries, all northern countries, and you can see here that there is number one, different figures, despite the fact that they are all neighboring countries, and theoretically they should be exposed to more or less same ambient influence. But as you can see, the numbers are very different. indicating that, of course, populations are different, the degree of immunization are different, the way of making the diagnosis as well, and this explains to some extent these differences. This is, again, in older adults of more than 50 years of age, and in this 10 years of a study, you could see that Norway had arrived to an incidence rate of 30 per 100,000, which is quite high, as compared, for instance, to Sweden, which is globally much lower. If you look this much more in detail, you can see here that the curves of the incidence rate changes very much in different countries, and of course changes over the years. And you can see the influence of the vaccination programs and the different outbreaks. Just to give you an example, this is a country, Sweden, here, where vaccination is not promoted in the adult and has been a constant increase in the number of adult cases from 2010 to 2018. In other countries, for instance, like in Germany, there was again an increase in incidence rate from 2012 to 2013 until the vaccination program was started for this population, and we have now witnessed a constant reduction in the number of new cases. It is important to know for the clinicians, particularly for the physicians dealing with the adult population, that although the disease can be very severe, and in fact high mortality rates can be seen among the very, very young, in the adult, the disease is certainly a nuisance and can cause problems, but the mortality really is very low. In the US, between the years of 2008 to 2011, more than 80% of all deaths involved infants less than 3 months of age. This is certainly the most vulnerable population, and is one of the reasons to understand why it's very important to have a highly vaccination population around to avoid the transmissibility, the transmission of disease to these young infants. And although school-age children are the source of infection for most households, adults are often the source for cases in high-risk infants, particularly those that are adults with asymptomatic disease, and we believe that they serve as the reservoir of infection between the epidemic years. Now, immunity is complex. Both humoral and cell-mediated immunity are important in pertussis. After natural infection, the immunity is not lifelong. This again justifies this meeting, and subsequent episodes of clinical pertussis are prevented by intermittent subclinical infection or revaccination. The duration of immunity after whole cell pertussis vaccination is short-lived, with little protection remaining after 10 to 12 years. The waning of immunity is even more rapid in adolescents and in children who have been received all of their immunizations with acellular vaccines, that is in 2 to 4 years after the 5th or 6th dose. As the clinical features, I already highlighted the importance of the paroxysms of whooping cough, which classically are worse at night, and the duration of the disease that can be many, many weeks. Now, the complications are mainly seen in infants, but in all populations, due to the increased intrathoracic pressure, you can see subconjunctival hemorrhages, abdominal and inguinal hernias, pneumothorax, facial and truncal petechia can result from this increased intrathoracic pressure. Weight loss can follow decreased caloric intake. Urinary incontinence, rib fracture, carotid artery aneurysm have also been reported in adolescents and adults. And finally, just to address the therapy for the infection, it is very important to know that the treatment has to be established quite early in the so-called catarrhal period, in the first 2 weeks of disease. This is when the use of antibiotics is not only necessary, but it clearly improves the course of the disease, shortens considerably the course of the disease. The mainstay of therapy are the macrolides, any of them, although for reasons of easy of administration and certainly efficacy, probably azithromycin and clarithromycin are the two best choices among the macrolides. Resistance of pertussis to macrolides is very rare, has been described, but again, it's very rare. And if for whatever reason a macrolide cannot be administered, then trimethoprim sulfamethoxazole is the best alternative agent known for these patients that cannot be treated with macrolides. Thank you very much for your attention.
Thank you so much, Dr. Garau. What a fantastic foundation. There's a lot there that I didn't know. So thank you very much for sharing. And I already have a number of questions percolating. But before we dive in, we have a couple more exciting presentations. So it is now my pleasure to introduce my colleague, Ms. Victoria Adepitan, a project officer at the International Federation on Aging and a lead for the Boosting Knowledge Towards Action on Adult Pertussis Vaccination project, of which she will be sharing some of the key findings with you today. Victoria, thanks so much for joining us today. The floor is yours.
Thank you very much, Anna, for having me. Hello, everybody. My name is Victoria Adepitan, Project Officer at the International Federation on Aging, and it is my pleasure to present the findings of the IFA study titled Boosting Knowledge Towards Action on Adult Pertussis Vaccination. The overarching aim of this project is to position the adult pertussis vaccination as part of the national immunization plan in countries. In order to accurately understand the problem, this study included 5 countries: India, Mexico, Brazil, and Vietnam. The objectives include sharing findings gathered from experts' interviews, and then identify gaps in the vaccination program and build a network across disciplines to promote adult pertussis vaccination and to inform policy. The world's population is aging rapidly, and it is expected that by 2030, the number of people aged 60 years and older will be 1.4 billion. That is 34% higher than the figure today. One might ask, why is it important to generate concern for adult pertussis vaccination? And why is it important to present a strong argument for funding? The answer is this. The current evidence suggests that the existing surveillance systems do not estimate the extent of pertussis. Also, the immunity elicited by childhood vaccination may wane over time and does not provide lifelong protection. Therefore, older adults may be at risk of more severe outcomes of pertussis infection and become a source of transmission to the infants. Given the estimate of a much larger incidence of this disease and the resulting loss of function and autonomy with poor health outcomes, the socioeconomic burden of pertussis in adults is substantial, and therefore adult pertussis vaccination and the broader use of the booster vaccines would be justified within national plans. So this is the overview of findings from the gap analysis and interviews conducted by the IFA. In Brazil, we found that 9.6% of the population comprises of older adults, and this is expected that by 2050, the older adult population will have increased to 65 million. Yet, Brazil does not focus on adult pertussis vaccination. The country includes policies and provides funding for pertussis vaccination for only pregnant women and healthcare workers who work with infants. Unfortunately, pertussis has been overshadowed in public health conversations by other pressing infectious diseases with more data and surveillance, for example, COVID-19 and influenza. Despite population aging and the increasing prevalence of non-communicable diseases in Brazil, there is a lack of awareness and policy dialogue around the need for adult pertussis vaccination. In Spain, we found that 20% of the population comprises of older adults, and this figure is set to grow at an annual rate of 1.47%. Yet again, pertussis vaccine is publicly funded for only pregnant women and healthcare workers in obstetrics or pediatrics. A major factor contributing to the absence of adult pertussis vaccination in Spain is the lack of awareness of the true prevalence of the disease among adults. Pertussis can be difficult to diagnose in adults as it does not present with typical symptoms. And this in effect means that the epidemiological data in Spain may inaccurately report case levels. In Mexico, again, 7.26% of the population comprises of older adults, and this figure by 2050 is set to triple. Yet again, vaccination against pertussis is only funded for pregnant women, while other adults must purchase it for themselves by paying out of pocket. One of the barriers for older adults to be vaccinated against pertussis is the lack of awareness to the availability of the vaccines. Also, older adults in rural and remote areas in Mexico find it harder to gain access to healthcare providers to get the appropriate vaccines. In Vietnam, 7.9% of the population comprises of older adults, and this proportion, again, is set to increase. So from what we can see from all countries, it means that there is an increase, there is a tendency that by 2050, there will be an increase in the older adult population. Now, despite this, there is a lack of adult pertussis vaccination in Vietnam, including for healthcare workers and pregnant women. Currently, Vietnam has observed a very low incidence rate of adult pertussis vaccination. Therefore, many policymakers and physicians fail to see pertussis as an issue for older adults and the need for including the vaccination in the National Immunization Plan. Since health system in Vietnam is limited, the National Immunization Plan tends to focus on where data identifies an epidemic. And now in Vietnam, data currently shows a high level of pertussis cases in children who have not reached the age of pertussis vaccination. And hence, Vietnam has introduced adding pregnant women to the recommended vaccination groups within the National Immunization Plan as part of an early pertussis vaccination program. Finally, in India, 6.24% of the population comprises of older adults. And again, the figure is set to increase at an annual rate of 1.39%. Currently, there is no adult pertussis program in the country. Underdiagnosis and underreporting are significant barriers to assessing the true burden of pertussis in India. The lack of surveillance and evidence on the burden of pertussis in India causes policymakers to dismiss the concern expressed by advocacy organizations and to refrain from including pertussis vaccination to the National Immunization Plan. A cross-country comparison. So while each country faces unique challenges, there are overarching similarities that can be leveraged to help address and inform the inclusion of adult pertussis vaccination within national programs. Across all 5 countries, the proportion of older adults is very high. Also, there were few examples of adult recommendations for pertussis. For example, recommendations were made for pregnant women and healthcare workers, like we saw in Brazil and in Spain, while in other countries, adults were entirely excluded from recommendations, like we saw in India and Vietnam. Finally, pertussis under recognition and under notification was highlighted across countries as a major hindrance to both the awareness of the disease and an improvement in uptake rates of pertussis vaccination. So what is the way forward? Having highlighted all these gaps, we ask ourselves, what's the way forward? The first thing is data collection. Data collection is a very critical element to help generate concern for older adult pertussis cases, to guide policy dialogue, and to present a strong argument for funding and therefore equitable access to pertussis vaccination. Secondly, it is also urgent and crucial to strengthen multi-stakeholder collaboration to better inform public health policies and advocacies surrounding adult pertussis vaccination in order to increase awareness and to improve the uptake rates of adult pertussis vaccination. The IFA sincerely thanks and acknowledges participants of this study for sharing their perspectives and their insights. And the IFA would also like to thank GSK Global on the funding of this project through an unrestricted educational grant. Thank you very much for listening.
Thanks so much, Victoria. I think, again, I've seen this project many times, but I think the gaps that you've highlighted are even more daunting, having heard Dr. Garau's presentation. So thanks very much for sharing that, Victoria. With this in mind, it's now my pleasure to introduce Dr. Isabella Ballalai, Vice President of the Brazilian Immunization Society, who will be speaking with us about the importance of including adult pertussis vaccination within national immunization programs and some strategies for strengthening stakeholder advocacy. Dr. Ballalai, thank you so much for joining us today. The floor is yours.
Thank you, Anna. Thank you for the invitation. It's a pleasure to be with all of you. Good morning and good afternoon for everyone. So I will present to you not about the importance. I think the importance to vaccinate adults. We know, but we have to have more data for each country, like Victoria have present to you. And I will talk to you about how to include this vaccine in the national immunization program. So I love these pictures, and it's about aging, the population aging in every planet, in all the planet. So whooping and the aging of the population, what change with them this when we speak about vaccination. So there is the Brazilian example. We have an increase of life expectancy of 30 years, and in a few years. And when you look our status today and future, I'm gonna demonstrate to you. Sorry. And we can see how this pyramid is changing, and the future of a country that is a traditional young country, a traditional country of young people. And this, with no vaccination for adults, can be the new epidemiology. You're gonna have not only pertussis, but other infectious disease like measles in adults in Brazil. We know, and Javier they have said the immunity pertussis adquired and the natural pertussis with the natural immunity and the vaccine immunity, it's not lifelong. And we can, when we have this situation and the young people are vaccinated and the old people are not vaccinated, there we can have the change of the epidemiology like you see now with pertussis. So the vaccine, pertussis vaccine, can protect for 5-6 years. And one question we don't have the answer, really an answer, if the vaccine of whole cells protected for more time than the acellular one. And the data demonstrates that acellular vaccine protects for long time. And it's more an problem, and how we have to think not only about adult vaccination, but adolescent vaccination too. this is the story of the immunization and epidemiology of this infectious disease. So if we don't have a high vaccination, the incidence of this disease or more incidence in first years of age. Natural boosters is frequent. Immunity in adolescents and adults exists because the natural booster and the disease prevailing in young children. This was the epidemiology of pertussis before the vaccination. But with a high coverage rate of immunization against pertussis. Low incidence is what we have. Less frequent natural booster. It's very hard, this natural booster today in the moment. When immunity in adolescents and adults, they are not vaccinated and they are not exposed to this natural booster with children with pertussis. And the disease prevailing in young children under 6 months, children that are not vaccinated, and in adolescents and adults. And so in the moment in Brazil and in all countries, we have low coverage, vaccination coverage. In Brazil, for example, for the vaccine with pertussis, it's the coverage for children under 5 years old are 50%. So now we have another problem. Children not vaccinated and adolescents and adults without immunity. I love to do this question. Have you seen Bordetella pertussis? Is the big problem. People, these authorities don't see the Bordetella pertussis. We don't see the Bordetella, and we don't see the case of adult and older adult case. We have inadequate surveillance technique to assess the full extent of the problem caused by pertussis or the impact of new strategy, vaccination strategy. We have to demonstrate this impact, the pertussis impact, to have to be listened by the authorities of all countries of the world. And when we have this outbreak, 2002 to 2012, 2014, and 7 were under 6 months of age. So approximately 61% among these 7 were under 6 months of age. So we know the impact of this disease on children. And because the diagnosis is more easy, the symptoms are very characteristic, and it's a severe disease in these younger children. So we have the greater demand for health service and a greater number of diagnoses in children, but not for adolescents or adults. This example from Australia, with the vaccination with children, they have decreased the number of cases in children and increase of cases in adults from 18 to 64 years of age, and an increase of case in older adults too. Routine pertussis immunization has dramatically reduced disease incidence. But in the past 20 years, there has been a change in the epidemiology of pertussis, such that adolescents and adult pertussis continues to be a global concern, even in countries with relatively strong economies and high rates of childhood immunization. And there is this country, every of these countries that have the increase of the change of the epidemiology, demonstrate the change of the epidemiology, use the acellular vaccine for pertussis. And it's a discussion about how the use of acellular vaccine for children can increase, reduce the time of immunization. So, answer, we need respond about pertussis, who is transmitting the Bordetella pertussis to children, because it was the bigger problem when we have outbreaks. And the vaccination, the pregnant vaccination, it's a very good strategy to reduce the number of cases in these children under 6 months of age. How to protect these children under 6 months? So again, the pregnant vaccination is the most cost-effective strategy to do this. So when we think about children, vaccinate children and vaccinate the pregnant woman. But what is the impact of pertussis on adults and the elderly? So the WHO recommends that a decision to introduce adolescent and or adult booster only be taken after careful assessment of local epidemiology. So it's because I think the main action we have to provide for countries to increase are the capacity that to diagnose and to do the surveillance of this disease. Estimation of the contribution of adolescents as a source of infection of young infants. It's not clear because we don't see case. So we have to know if adolescents are seeking with pertussis or not. Selection of adolescents and or adults as target group for vaccination. Okay, if you have this data, it's what you have to do. The Brazilian National Immunization Society recommend in this vaccination schedule, the vaccine for all population, 10 in adolescent and adult for all life. The idea is to replace the double bacterial vaccine, diphtheria and tetanus, by the DTPIA vaccine. Decision concerning such programs should be based on the incidence and cost effectiveness data. We can't include a new vaccine in national program immunization if you don't have this data. High coverage or routine immunization, in fact, must be in place prior to the introduction of vaccination and of adolescents and adults. A second problem is to to be that if we include the pertussis vaccine for adults and adults and of older adults, we have to be sustainably. We have to have vaccine for all countries that decide to be this. And I think if all countries decide to include this vaccine now, I think we don't have vaccine to this. So the manufacturers can have to prepare them for this change of recommendation worldwide. There are several challenges in estimate the aging pertussis disease, the global pertussis disease burden. Limit surveillance infrastructure. Most countries don't have this infrastructure, don't have the text. Laboratory infrastructure to support routine pertussis testing is limited, and molecular diagnostic tests such PCR are not uniformly available in the world. Inconsistent clinical identification of pertussis disease may hinder case reports, and the application of a standardized set of pertussis case definition within an overall surveillance framework has not been as now. And when we speak about recommendation from WHO, it's the priority for children under 5 years old. The pregnant woman vaccination as the most cost-effective additional strategy for preventing disease in infants, more than the cocoon strategies and less cost for the country. Healthcare worker, really, there is no really reason to choose the healthcare worker to be vaccinated against pertussis to protect the children. I think more important it is to vaccinate household, the parents that have more exposition with their children, and adults and the elderly. WHO said decisions concerning such program shall be based on the incidence and cost-effective data. So WHO consider that adults and old adults against pertussis, it's an important strategies, but need to be more to have more data for this. What we want, 95% or more of vaccination coverage for children under 5 years old. The same for vaccination coverage for pregnant women, and include the recommendation for vaccination of most vulnerable groups, older adults first, and adults at risk group, as people who live with chronic comorbid condition. So our problem and what action you have to propose, you have to encourage countries to seek to know the local burden disease. This highlights, demonstrates the importance of surveillance, not only for pertussis, but for all immunopreventable disease, even many years post vaccine introduction. So you have to speak with health authorities and health care professional. Another question: how long these dose? How many booster you have to done? and more efficient allocation of resource is important to decide, and we have to have more data to know this. You have to communicate with the target population and adopt strategies that help adults to inform decision about vaccination. This is the immunization agenda 2013 from WHO that consider a world where everyone, everywhere, at every age, fully benefits from vaccine for good health and well-being. Thank you for your attention.
Thank you so much, Dr. Ballalai. Again, just a really interesting information there. As we move forward into the Q&A, I just want to let all of our speakers know that I'll be coming back to you towards the end of the session for just some key takeaways that you'd like to share with the group. But in the interim, we have some really interesting questions that have been rolling into the chat, and I would encourage participants today to kind of add their questions there. But in the meantime, I wanted to talk a little bit, because I think it's been a bit of a common thread throughout all the presentations, this topic of data and kind of the lack of data available. Dr. Ballalai, you talked a little bit about kind of there often being a lack of infrastructure for surveillance, but I'd love to know, and kind of your opinion across all presenters around some strategies to kind of increase data surveillance, because as we know, we don't know the scope of the problem really within older adults or how to address that without appropriate data. So from kind of both of your perspectives, how do you see kind of tackling that issue? How can we increase the data and surveillance available for adult pertussis vaccine?
Well, if I have to tell you what I think that we have to be sure that the public health service is absolutely aware of what's going on with pertussis in each country, because obviously the answer will be different depending upon the incidence of disease. Now you are really asking, how do we know where we are? And this, in my way of thinking, means two things. One, that the pediatricians and the family physicians have to be very much aware of pertussis, and they have to think that pertussis is not an old disease that is no longer present in our world. And it is, I have the bias of being an internist, and each time I face an adult, any age, that has cough for more than 2 weeks, particularly a patient doesn't have any other comorbid conditions, particularly if this has happened in a period where there has been an increase in pertussis in children, I immediately think that we have to rule out pertussis. In doing that, we and many others have documented that maybe up to 20% of people infected with pertussis are adults, which spread, in my way of thinking, is an important segment of the population that spreads the disease, because many of them are asymptomatic. And of course, this is the case when we are talking about parents and healthcare workers.
Thanks so much, Dr. Garau. Dr. Ballalai.
I agree with Javier, and I think we have to remember these authorities, that this, what I tried to say to you, that the epidemiology of preventable disease with vaccination change, and it's time to know what happened with adults, and especially older adults, not only pertussis. They have to know this. So this is the first thing. And about text, we have the majority of the planet don't have this structure, don't have money for the text, access of the text. And so you have to speak a little bit about this with these laboratories that create the text, to have text with low cost and can be accessed for all countries. But the main thing is to demonstrate for these authorities that pertussis in older adults and older adults, it's a problem we don't see, but this problem exists and can be increased. The problem can be increased.
Right. Thanks very much, Dr. Ballalai. Related to that, and kind of dovetailing off of your last comment there, Dr. Ballalai, we have a question here from Shmuel, who's asking a little bit, have you, in your experience, either of your experience, seen any differences in kind of the incidence within low-income populations? And are there any strategies to improving the accessibility of pertussis vaccination within these populations? I know you talked a little bit about, again, that lack of infrastructure, Dr. Ballalai, and the cost of testing and things like that. What are some of the other barriers, and what are kind of some of the strategies to mitigate those barriers in low-income settings?
It's because the majority of countries, no-rich countries, use the whole vaccine. Because change for a cellular vaccine will be more have a big cost for this country, and we have the chance to not have a cellular vaccine for all countries. We have to think about this. So a cellular vaccine in Brazil, it's for adults because does not exist a whole vaccine for is not recommended for these people, and to have access for all. I think all countries have access for DTP of whole vaccine, and every country have to have a strategy to offer access of all countries. In Brazil, we vaccine indigenous, we vaccine vulnerable persons on the country, and I don't know if it's what he want, or there is more I can answer for him.
Dr. Garau?
Well, I think that we have already stressed that every country is a world in itself, depending on the mean age of the population, the immunization rate, and other factors. You will have a different picture. I have shown you data from Northern European countries, and you can see that although they are of high income countries, developed countries, the situation is different from one to another. So it is true that when you are dealing with a developing country, particularly talking about vaccination, the vaccination rate globally probably is lower, and that this is a very important point. And therefore, I would stress that in this situation, the first goal as far as pertussis is concerned is to be sure that the immunization rate is at least above 90% in children. This would be the first step, and this is essential. Now, this is the situation, by the way, or we think is the situation in Europe in general. And what we have seen is that despite the fact that the immunization rate is high in all of these countries, developed countries, all of them, we still have, no question, small epidemics. This is true, much less than 40 years ago, among the adults, young adults and older adults as well. And we have to design, as Isabella mentioned several times, a specific program depending upon the specific situation in each country. My own country, this has been, by the way, highlighted by by previous speaker, that indeed the growing elderly population is becoming more and more important. And if we compare Brazil, for instance, with ourselves, we have a very close to 20% of our population is above 65, as compared to Brazil, where the situation is different. And obviously, this requires a different approach. Right now, I can speak about my country, we don't have a specific program for the adult. What we have is a specific program for the pregnant women, and if has been an outbreak, for the healthcare physicians in general, physicians and nurses, for the healthcare personnel. Isabella mentioned something that I believe is also interesting. The parents should be also a target for vaccination in this particular setting, I think.
Thank you very much,
So
Dr.
can I?
Yeah, of course. Yeah.
About what Javier have said about vaccine coverage in different countries. Now we have lots long coverage than Europe. It's a new word.
Mm.
It's very dangerous. It's very dangerous because with the pandemic and if infodemic, we have now in Brazil and Latin America countries the anti-vax.
Yeah.
Like you have in North American and Europe countries. So this change the scenario, and very important to include a new vaccine for anyone is to work the previous of this inclusion. We have to speak with the health profession about this vaccine. Health profession do not understand about vaccine. We can see this when we receive the new COVID-19 vaccine. They know about vaccine and about prescription of vaccine. But when it's a new vaccine and when you have the anti-vax, health profession are an important group that have doubts about the vaccine.
Thanks very much, Dr. Ballalai. It's a really good point and something that is on our radar for sure. Again, I think we could probably continue this discussion for another hour, but we're quickly approaching 10 o'clock here in Toronto. So I want to give the opportunity for both of you to kind of leave us with some closing remarks. So I'll start first with you, Dr. Ballalai, and then I'll come to you, Dr. Garau. Dr. Ballalai, closing.
Thank you. It was very good. And I think we have so much to do to increase adult vaccination.
Thanks very much, Dr. Ballalai. So the urgency of the work we need to do is your take-home message here. We have got a lot of work to do, and we got a lot of work to do quickly.
Yeah.
Sounds good. Dr. Garau, final remarks from you?
Yeah, I think Isabella mentioned that, but I'd like to re-emphasize the fact that today, after the almost 3 years of COVID-19 all over the world, the immunization rate for all vaccines in general has been markedly reduced. And this poses very important problems. And we start to see here and there a surge of vaccine preventable diseases, which means that in one way or another, we have not been able to convince the politicians that indeed this is very important, and that once again, a global solidarity has to be reached to be sure that the vaccination programs are really admitted by the population, and that we, in one way, are able to face the anti-vaccine movement that is everywhere.
Thank you so much, Dr. Garau. I think some really, really important messages here, and kind of that we too are seeing the kind of the waning of priority or importance of other vaccinations in the face of COVID. So I think that's something that we all need to keep kind of top of mind. We've reached 10 o'clock, so I just want to take the opportunity to thank everyone who joined us today, and those of you who will be, I'm sure, engaging with these materials post-webinar. And just again, thank you so much, Dr. Ballalai and Dr. Garau and Victoria, for all of your time and work and expertise that you shared with us today. We hope you all have a wonderful day, and hopefully this is the first of many discussions. So thanks very much, and we'll see you next time.